I'm Richard Heffner, your host on The Open Mind for the last half century. And all of these years, I've had a favorite informant whispering into my ears perfectly terrific suggestions about guests I should invite here. Wonderful thinkers and speakers that she, my wife, as a practicing psychotherapist herself, had heard at Cornell Medical School's provocative medical education grand rounds. Well, Elaine Heffner has done it again, told me some weeks ago about Dr. Sally Satel, practicing psychiatrist in Washington and a resident scholar at the American Enterprise Institute, whose Ptsd, How Political Correctness is Corrupting Medicine, is one of her provocative books. Another is One Nation Under Therapy, How the Helping Culture is Eroding Self-Reliance, which she wrote with Christina Hoff Sommers. And I'd like today to ask Dr. Satel first to describe some of the controversies these books have occasioned. Is that fair?
Yes, that's fair. Yeah.
What have you stirred up?
Well, I think I stirred up a hornet's nest in almost each chapter, but the first one seemed to get the most attention. That was a critique of schools of public health. Now, don't get me wrong, most people who go to a school of public health can get excellent training in epidemiology and disease tracking and research methods, but many of these schools have a department of social medicine, and they tend to be fairly politicized. And so that's what I wrote about in that chapter.
What do you mean politicized?
Well, they don't stick so much to data. They really have a political agenda. An example is actually income distribution. That is one of the agendas of a few professors at the Harvard School of Public Health. I'll just pick that one, but several others. In fact, the former dean of the Harvard School of Public Health had said, a school of public health is like a school of social justice. In other words, all the ills of society are something that many, though certainly not all, public health academics see as their purview. For example, we know that health and wealth correlate. There's no question about that. So what would be an approach to that? Well, if we want to make everyone healthy, then we should redistribute wealth. This is a literal recommendation from some of these folks.
All right, Dr. Satel, what's the problem with that?
Well, there are several problems with it. One, they're mistaking often correlation for causation. There are a lot of reasons why people at lower income have poorer health. Certainly, a part of it, there's no question, is when you have more money or certain kinds of jobs, when you're sick one day, you literally can take off and you won't lose your job. You can go to the doctor in the middle of the day, and a lot of jobs that our colleagues would have, and someone who works on an assembly line or the kind of job that's an hourly rate really does suffer if he takes any time off, and many clinics aren't open at night, that kind of thing. That's very practical and very, very true. But there's a lot of problems with self-care among the poor. Now, I realize that when your life is chaotic with so many other problems, paying attention to your health is often not the first thing on your mind. I appreciate that. But in my clinic, I work in a methadone clinic, and when I see a patient with asthma, the first question isn't what asthma medications are you on, it's how many packs a day do you smoke? People continue, in that particular example, to smoke when they already have asthma. They're in a methadone clinic. They often continue to use heroin. They have diabetes, and they don't watch their diet. I mean, these are things that people can do for themselves, and there's very little acknowledgement of that because it would seem to them as if it's blaming the victim.
So you're saying, if I understand you correctly, that there has to be a level of responsibility on the part of the patient so that you don't treat the patient simply as a victim.
Oh, definitely. There has to be responsibility. And always the flip side I mean, someone can say you're blaming the victim, but what I always say is, well, actually, if the flip side of that is showing someone where they can take control. But you asked, why is that kind of approach to health? Why is this grand scheme, this global conceptual approach to public health invalid? Well, first off, as I said, it doesn't recognize all of the causal dimensions. Secondly, it doesn't work. You're too far upstream. I mean, in order to redistribute health, as if that would even work, you would have to essentially reorganize our entire society. I mean, and that's not a job for a public health professional. That's jobs for politicians, and not that public health folks can't participate in those debates, but I think that their most constructive role is to provide the empirical basis for these kinds of policy changes.
You're saying then that they're not doing what they need to do?
I'm saying they're not doing what they need to do. They're highly distracted by, again, political agendas. There's now a big literature on something called health disparities. Now, disparity is a perfectly neutral word. It just means different, but it has come to now mean injustice, and it refers to the difference in health status between whites and blacks, or whites and minorities. And there's no question that there are these differences. Whites have longer life expectancy. They're generally more healthy, better infant mortality, lower infant mortality rates, often more likely to get certain procedures in a hospital. All this is true, but one of the major inferences on the part of some folks in public health and in medicine in general is that this difference is actually due to racism or to prejudice on the part of the healthcare system. And I've done work on this. First off, it's a very hard thing to prove that there's any kind of bias, unless we're talking about, direct discrimination, in which case we have a legal system to help resolve that. What we're talking about are differences that stem from socioeconomic class, again, self-care. If you want to invoke bias as an explanation, that's always essentially a diagnosis of exclusion. It's when you've ruled out everything else, the geographical variation in healthcare availability, the, again, socioeconomic status of people and their access to care.
But the question I would think that would be most important would be, what do we lose? What does this approach, what does this politically correct approach, where does it damage the patient or society?
It damages the professions that practice it because they're really not focusing on what their expertise is. For example, last year the American Psychiatric Association came out in favor of gay marriage. Well, I'm not against it. I'm not for it, I'm not against it. That's irrelevant. And that was my point. This is irrelevant for a professional organization, which is supposed to specialize in research, education, and patient care, to take on these social issues. It's just, first off, at minimum, it's a distraction from what they should be doing. They lose their credibility. I think it damages the credibility of a professional organization when they take on these social issues. It's also not representative. I think it causes tension within those professions because not everyone, we're not a monolith. They're not representing me when the APA gets up there and talks about gay marriage. As I said, either way, the particular policy decision is not what I care about. It's the fact that they've engaged that debate at all. So that's one. I think it damages the profession and also loses credibility in the eyes of the public. And they're not doing the kind of, whenever they work on issues that are really not within their professional domain, they are not doing the important things. We're not in psychiatry, for example. I don't believe we're worried nearly enough about the severely mentally ill, but instead we're worrying about vague kind of trauma initiatives, and we can talk about that another time, but the idea that, if you were abused as a child 30 years ago, maybe, that is the reason why you're troubled as an adult now. And it's it's such a distraction. We should deal with people, obviously, in their distress as they present, but to have special initiatives for people that inculcate them further in the idea that they're victims and that they've been, and that they then often can't move on because they get so entrenched in this sense. It almost becomes their identity sometimes, that it can lead to bad treatment as well.
Trauma. This is a subject that does interest you and that you have written and spoken about.
Yes.
What's happened in the world of psychiatry, given the question of new definitions of illness that relate to trauma?
Well, there is no one questions the reality that a person can experience a truly horrific event, a rape, combat, terrible accident, a hurricane in which, your life was almost threatened, that people can experience these catastrophic events and also develop mental illness afterwards. In other words, what we've come to now call post-traumatic stress disorder, marked by a re-experiencing of the event. You keep having these horrible intrusive memories, can't sleep, hyperarousal, a kind of phobic avoidance of the situation, which can get to the point where it really does impair someone's life significantly. Most of the cases, this is self-limiting. Doesn't mean one shouldn't get treatment. My point is that this is a real phenomenon, that people can go through horrible situations and develop some kind of mental pathology from it. But unfortunately, that diagnosis, PTSD, post-traumatic stress disorder, has been so watered down that to the point where if you just experience something distressing or hear about a horrible event that's befallen someone else, and you too can qualify for PTSD. It's almost become a narrative of suffering, and it medicalizes what are often normal human reactions to very, very tragic events, 9/11 being one of the most striking examples.
Now, you don't see this as a response to some mass demand for help. You see this, if I understand correctly, as a new business.
Well, I do think some of it's manufactured. I think there's a very crass level of commercialization of it. For example, there's a group called the International Critical Incident Stress Foundation. It's just run by someone who is a former EMT, and they give workshops and they get contracts after a tragedy, and they all run out. The busloads of grief counselors and trauma counselors that descend on these scenes, and they get paid from these kinds of things. These are not usually physicians or PhDs. These are people at a master's level or lower, not the most sophisticated, often well-meaning, but that's a business, and I gather it's quite a successful one. But I'm also talking about academics who, and this is no surprise, people who spend their whole career in a specialty, and they need to get grants, and they need to fund their research empires, have an investment. It may not even be that conscious, but there's no question there's an investment. And I do think that they have very much contributed to the popularization and the dissemination of this construct.
And what is this construct doing to us as a people?
Well, that's always a good question. I can tell you what it's doing to veterans at the VA hospital, because that is an institution where it's most concentrated. I think it has largely backfired. As you know, post-traumatic stress disorder, while it always existed in nature, as I said before, as essentially a fear reaction that didn't extinguish after the trauma subsided, but as a formal diagnosis, it didn't exist till 1980, when it was adopted in something called the Diagnostic and Statistical Manual of the DSM, which is the APA's diagnostic handbook.
And making it legitimate.
Yeah.
Crowning it.
Definitely legitimizing it. It was put there, this is not really a disputed point, it was largely put there by two psychiatrists who were self-avowedly anti-war. It was very much embedded in the context of the Vietnam War. And in fact, the first iteration of PTSD, when it was proposed, because it was proposed in 1972, and the APA thought about it for years, actually. They spent a lot of time on each new edition of this diagnostic scheme. And, but when it was first proposed, it was called post-Vietnam syndrome. Now, heaven forbid someone's spouse dies, or they lose their job, or they get divorced, and they get depressed about it. There's no post-divorce depression or post-disappointment depression. It's depression, and again, you treat the individual based on what his situation is. So post-Vietnam syndrome was just unacceptably specific and unacceptably politicized. In fact, the anti-war psychiatrists who were pushing it, Chaim Shatan, Dr. Lifton, were, I think, unabashedly trying to also signal that it was an anti-war slogan. Go to war and your mind is annihilated afterwards. And they also introduced the idea that PTSD could be chronic, that this could go on for years. And they basically gave rise to a PTSD industry within the VA. And I worked there, in fact, in the mid-'80s, 88 to 93, excuse me. And I saw how, and I should say that the clinicians were very well-meaning, and a lot of it was state-of-the-art therapy at the time. But how they saw every problem that someone had once been in a war, once you'd been in a war, that anything that happened in your life subsequently, could be walked back to that seminal event. And it's true, there are some patients, I think they're probably quite a minority, but some patients who were so derailed, so traumatized by the war that they never did regain their footing, and that they did become chronically mentally ill because of it. And the VA has a very generous disability program, and they certainly deserve that. But there are a lot of people who came back and probably had some readjustment problems, but it wasn't pathological. It was sort of a social dislocation. And later in life, 20 years later often, they had some life problems, because who doesn't? And they came to the VA, and this was the narrative that so many clinicians would even impose on them. In fact, I just got an email. I get a lot of emails from veterans, most hostile, but yesterday I got one from someone who was very reasonable, I thought, and he said, they're convincing me I have post-traumatic stress disorder. Now, from Vietnam, which is a very interesting phenomenon. Can someone develop a stress reaction 30 years after an event? I don't think so. I'm very skeptical of that.
Now, a little aside, for a moment you said most of them are hostile, these emails. Why?
I knew that would catch your attention. Well, they think that I'm denying the very existence of post-traumatic stress disorder, and I don't do that, but I am skeptical, and I'm certainly not going to muzzle my doubts about the fact that, as I just said, someone 30 years later can present to the VA and want lifetime disability after this.
You're pretty skeptical about a lot of things that relate to social medicine, or medicine that has a social or political content.
Well, of course, because you're not serving the data first, and you're often not even serving the patients first. You're serving a larger mission, and that should make anyone skeptical, and it also should make anyone worried that, we did take an oath, and the patient always comes first, not your politics.
When you say the patient comes first, you are dealing with individuals here, right. Someone who wants the benefits of this new philosophy. Are you really thinking of the patient then when you express your dislike for what is happening to us as a society, becoming less and less self-reliant, more and more reliant upon these kinds of social objectives?
I'm not quite sure I understand the question.
Well, I don't blame you, because as I went on, I was wondering what I was asking you, because I was trying to avoid asking you whether you're reflecting a political point of view.
Oh, I see what you mean. I really don't think I'm reflecting a political point of view. Unfortunately, these days, championing personal responsibility puts someone on the right.